Hello everyone and welcome back to The Endoscopist. Today I want to share with you a very interesting case of esophageal inlet patch with low-grade dysplasia, which was accidentally discovered during upper endoscopy, which of course is a very rare situation because usually inlet patches are very benign. So the case was referred to me for endoscopic resection, and we have chosen to go for endoscopic submucosal dissection for resection technique. After marcation of the lesion, I, as usual, start with the lower margin. I inject first saline, then I cut the mucosa of the lower margin, and as you can see here, I go after the cutting the mucosa for trimming. And with trimming, our aim is to cut all the fibers of the muscularis mucosa, which will make the finish of the procedure much easier. After finishing the lower margin, I went for the right margin. So we start from proximal or from above going downwards, trying to connect this cut to the lower margin that we have just done. After cutting the mucosa, again I go for trimming for the right margin, and after finishing that we proceed to the left margin. Again the same, we inject and then we cut the mucosa from above going downwards, and again try to connect our cutting line to the lower margin. So now we have like a U shape, left, right, and lower margin are very well cut. Now is the challenging part, which is the upper margin. And this was very challenging because of three things. First of all, the high proximity of the lesion, the narrow space, and the severe fibrosis, as you can see here, which we needed to cut to go into the submucosa. The lesion was about less than 1 centimeter below the upper esophageal sphincter, which fixated the tip of the scope, making the maneuverability very limited. But again, going step by step, we were able to cut the fibrous tissue and open the submucosa. After opening the upper border, we have a circular cut. After that, we can proceed with normal submucosal dissection, which is quite easy. Again, still challenged by narrow space and lack of maneuverability of the scope, but sometimes I have to work, or I had to work from a distance, which is not ideal, but in this situation it was fine to do very cautiously. So we dissect step by step very cautiously till we finish our dissection. It's very important here not to make any muscle injury because we are in the upper part of the esophagus. Repair here will be difficult. We cannot fix a stent or anything if needed. Again, here you can see in many parts there is a lot of submucosal fibrosis, maybe from chronic inflammation as well as from the vigorous biopsy that was taken during the first diagnosis. That shows us here this lesion, how that we have every time whenever we are doing upper endoscopy to do meticulous examination of every part of the esophagus. Even for inlet patches, which are very common and usually they are very benign, we have to examine them very meticulously. So here are the last couple of submucosal fibers we are dissecting. And I think you can appreciate here again the lack of maneuverability of the lesion. This is the final cut here, and we finished the dissection. The dissection itself took about 35 minutes plus. We are examining the wound area to make sure that we don't have any submucosal injury. And then, as usual, we go with coagulation forceps to coagulate any visible vessel. And prophylactically, I put Purastat to prevent bleeding, and I give the patient after that budesonide or Jorveza for 2 weeks to prevent any strictures. As you can see, stricture didn't happen because it is less than 50% of the circumference. After I finish, as usual, I examine the specimen ex vivo with near focus to make sure that everything is out. Thank you very much for watching, and see you in the next video. Bye-bye.